Hello, my name is Valerie Twomey. I am the Brain Injury Programme Manager at the National Rehabilitation Hospital in Dublin in Ireland. We provide specialised neurorehabilitation for people with acquired brain injury. I have been working in the area of neurorehabilitation for 18 years, and today I would like to share some of my thoughts, some of the changes we have made, some of the innovations that we've introduced, all of which come together to make a difference for the individual with acquired brain injury who seeks to avail of a neurorehabilitation service. During today's presentation, I would like you to consider and to ponder this question. Who is the most important person in the rehabilitation process? Is it our traditional, young, disabled, a brain-injured adult with complex physical, psychological, emotional, cognitive and communication needs? Or is it the medical rehabilitation physician who oversees and conducts and determines what the needs of this individual is? Before we come to any conclusions with this question, I'd like to have a look at some of the issues that influence how we approach our patients' needs in neurorehabilitation. Models of disability within which we work have a significant impact on the outcomes that our individuals with acquired brain injury achieve as part of the rehabilitation process. The medical model is the traditional model which has been used and also has provided a traditional view of disability for us in years gone by. This model sees disabled people as passive receivers of service, the impairment as being the problem, and what often results then in society is that we segregate and we separate, creating special facilities which are often away from community life. The social model, however, sees the person as disabled by society. In this view, the impairment is not in itself a problem, even though it may produce a need for a different set of living requirements. Rather, society's insistence on segregation in education and services and the inaccessibility of things such as transport and buildings results in a general prejudice against an integrated community life for disabled people. In this view of the social model, the disabled person is an active fighter for equality. The disabled person advocates and works in partnership with allies to create a society which is truly inclusive. At the National Rehabilitation Hospital in Dublin in Ireland, we have adopted the World Health Organization's International Classification of Function in order for us to put a framework and a model which promotes social inclusion for our patients and to cater for our patients' needs. Disability, as you know, is a complex phenomenon. It reflects an interaction between features of a person's body and features of the society in which he or she lives. Disability, according to the World Health Organization, is an umbrella term which covers impairments, activity limitations, and participation restrictions. According to the World Health Organization, it is the psychological and psychosocial factors and not the extent of the physical disability that predicts long-term overall adjustment. At the NRH in Ireland, we have looked at recovery and rehabilitation in some very interesting and innovative ways, and this has helped us to formulate and to structure a new program of neurorehabilitation, elements of which I will be sharing with you here today. If we look at recovery, what we mean by recovery is the return to a healthy state. For those of you who work in the area of acquired brain injury, and for those of you like myself who work in the area of acquired brain injury and its rehabilitation, you know that we often face the very challenging question from our patients, from the families with which we work with, who want to recover to their healthy state, who want to recover to their pre-morbid level of functioning. And we know that this isn't always achievable, particularly for those patients who present with moderate to severe to profound acquired brain injuries and who have complex disability needs. So what we advocate is that we hope to recover to a healthy state of ability and functioning. And when we look at the whole idea of what is rehabilitation, well, rehabilitation is to habilis, to and make again suitable. So rehabilitation means to make again suitable, and not necessarily in exactly the way that the individual presented prior to their illness or injury. And I think this is a very important point that we need to stress in working with some of these individuals. What we do in rehabilitation is to maximize function by adapting and preventing maladaptive behaviours, some of which I will talk about again later on. In the rehabilitative approach, we need to be innovative, we need to be very creative in how we design and how we implement our treatment programs. These programs need to be individualised. They need to meet the needs of the individual with acquired brain injury. And we need to work with what is available. Very often, the person with acquired brain injury presents with quite severe disruption in their physical, their cognitive, their emotional, and their psychological states. And we need to work with what is still present and maximise on their capacity. We also need to consider, in terms of our prognosis, the nature of the condition, which can be quite variable, the variable nature of those deficits associated with the condition. We need to consider quite significantly the pre-morbid factors that influence somebody's performance in a rehabilitation program. And we need to look at their personal goals. This is something which is crucial and central to the neurorehabilitative process. People are goal-driven. We need to be goal-focused in our approach to rehabilitation. And we also need to consider the post-morbid social and interpersonal issues. Persons with acquired brain injury following hospitalisation, when they move back into the community, are often faced with severe changes in both their social and their interpersonal circumstances. Relationships break down, individuals are unable to return to work, sometimes they even lose their accommodation, their homes, and we need to consider what is facing these individuals as challenges as we move on. The rehabilitative approach can enhance function at any stage in the recovery process. In the earlier stages, it is developing ways of managing difficulties so as to remain involved in roles and activities and have the opportunity to make a valued contribution in community life. Some of our approaches to neurorehabilitation include restoration of function, which looks at improving specific skills deficits. We need to look at compensatory training, which we need to apply and teach to our patients so that they can adapt to their deficits. And we also need to look at the environment from which the person has come and to which the person will return. We need to look at modifying this environment in order to suit their needs. Following acquired brain injury, as you know, an individual's brain goes through a process of natural healing, which is often called spontaneous recovery. This type of healing occurs most rapidly during the first 6 months after an injury or an illness, but it may continue for many years. So restoration of function and improving on skills that are continuously changing is very important. The purpose of the rehabilitation process is to help to accelerate this process of regaining functional abilities by presenting the individual with challenges that promote learning and improvement of skills. Although goals may be the same for many people recovering from acquired brain injury or illness, the route to get there may be very different for each person. In this regard, what we focus on in terms of our approach to neurorehabilitation is a combination of all three. We need to focus on the emotional, interpersonal and social areas. We need to improve adaptive skills. We need to promote better psychological and vocational outcomes. Each individual's neurorehabilitation program will vary depending on the severity and type of injury or illness. And for example, a person with severe physical problems and moderate cognitive problems might receive more physiotherapy and less cognitive retraining each day compared with an individual whose injury has resulted in severe communication difficulties but is independently mobile, and their program then will obviously emphasize more speech and language pathology. So what we need to do is advocate a combination in terms of approach, and we need to advocate for a variable and individualized program of rehabilitation for our individuals. Successful neurorehabilitation, we know from research and from the literature, is significant and is highly dependent on the amount of damage to the brain, skill on the part of the rehabilitation team, highly dependent on the cooperation of family, friends and carers. Caring family and friends can be one of the most important factors in the success of the rehabilitation program. And the timing of the rehabilitation program is crucial. We do know that for persons recovering from traumatic brain injury, where they have sustained their injury as a result of a traumatic accident or incident, we know that the earlier that the rehabilitation process begins, the more likely survivors are to regain lost abilities and skills. However, we also know at the National Rehabilitation Hospital in Dublin, having worked with disorders of consciousness, that working with an individual who is minimally conscious or is in a low-level awareness state, that the timing of your intervention, often 6 or 9 months post-injury or illness, is more important, and that assessing their needs in terms of communication and assessing their suitability for rehabilitation is better left for longer, for more time, if you like, post-injury. And this is something that's very important to consider. So the brain injury program at the National Rehabilitation Hospital in Ireland offers specialised, interdisciplinary, not multidisciplinary. Each member of our interdisciplinary team works with the patient in a joint, collaborative fashion in order to help the individual to achieve their goals. The program at the National Rehabilitation Hospital is very, very significantly goal-directed, and this goal involves patient, family and team members alike. And the individual with acquired brain injury is focused on achieving outcomes which are set, targets which are set by the patient and the family. So we offer a program which demonstrates commitment, capabilities and resources to maintain itself as a specialised program of care for people with acquired brain injury. I want to stress here with this particular slide that the patient is an active participant in the brain injury program at the NRH, and this we consider to be extremely important in the success of our particular program. The patient is active in planning, in selecting and in evaluating the services which are provided by the team. So how do we do this? Well, the patient is a central member of the team. He or she is involved in decision making at every level and at every step along the continuum of the program. He or she has rights with regard to both their personal and civil rights, which we must consider and we must advocate for. And we recognise at the NRH that the cultural and ethnic diversity of the patient is also very important. So let's talk a little bit about our approach in rehabilitation. Well, Aristotle, a very intelligent and very sensible man, once said that what we are, we repeatedly do. Excellence, therefore, is not an act, but is a habit. When faced with the challenge of caring for and treating an individual with an acquired brain injury, we as clinicians, we as rehabilitation specialists, must adopt their self-management and their difficulties by proxy. This often involves changing our attitudes and our approaches to the things that we need to do. It also involves changing our methods and means of accomplishing these. Habits are very powerful factors in our lives. They are consistent, they are often unconscious processes and patterns which constantly and daily express our character and produce our effectiveness or ineffectiveness, as the case may be. Therefore, working with a patient with an acquired brain injury, we must adopt their self-management in order to influence and educate them in relearning a lot of the self-management that they need to achieve in order to be successful in their rehabilitation program. So one of the things that we've had to consider at the rehabilitation hospital where I work is, do we offer individual versus group rehabilitation? And there are lots of arguments in the literature and in the research which advocate for both. In general, individuals engaged in rehabilitation are interested in individual processes rather than group processes. But it is the individual who has to return home, live in the community, return to work, and cope with his or her life. So what is the best way to deliver this program to the individual who must then take on these skills and these activities and reintegrate back into community life? A number of studies have reported that individual and group therapy can complement each other constructively. In one particular study by Programa, the therapeutic intervention for brain-injured adults with problem-solving disorders found that training in group presents patients with a far less structured situation than does individual therapy. And this then provides an opportunity for patients to best test their executive and cognitive abilities in order to improve on them. Programa also suggests that experience by close personal contact with fellow patients and the effects of cognitive impairment and behavioural peculiarities is most closely examined, assessed and treated in a group context. So therefore, at the National Rehabilitation Hospital in Ireland, we offer a mix of both individual and group therapy processes, which has been shown to be very effective in the successful outcome of neurorehabilitation. And group therapy does not necessarily just involve the patient and other patients with acquired brain injury, but also involves the patient working as part of his own social group, his family, his friends, and his wider community network. So the individual is encouraged to regain skills and abilities as part of that group process. With regard to our approach at the NRH to neurorehabilitation, we have over the years considered that what we do often for our individuals is management of their disability rather than cure. And I think it's important that we need to consider, in order to be effective and efficient in our programmatic approach, that management rather than cure is often what we are faced with when working with a patient with severe and complex disability needs. Nerve cells, we know, in the brain cannot come back to life to a clinically useful extent. With respect to the work that has been done on plasticity and neuroplasticity, which provides us with very, very exciting new information with regard to an individual's ability to regenerate and to reorganize at a neural level. At the moment, in neurorehabilitation, we still operate from a standpoint that the brain cells cannot come back to life to a clinically useful extent. And until further research and further information is borne out with regard to neuroplasticity, this is the way we will continue to work. Intact nerve cells' functions can still be used, however, to work around many of the difficulties that we encounter with our patients. And therefore, using compensatory strategies to reduce the impact of the disability upon daily life is central to the neurorehabilitation process. So why set goals? Why it is important for an individual involved in a neurorehabilitation program to set goals, both from the patient, the family and the team's perspective. Well, in a rehabilitation framework, we take account of the personal context and the surrounding social system of the individual. Intervention is aimed at disability and its restriction on activity and participation rather than at the impairment. Efforts should be invested in goals and targets that are relevant to daily life and are of importance to the individual. At a very practical level, ensuring that remembering is supported where possible by appropriate environmental cues is an obvious and simple intervention that can be applied in any situation. So why do we set goals? Well, goals are very important to motivate the individual, to motivate staff, and to motivate family and friends in the neurorehabilitation process. Goals obviously also provide direction for the staff and the family. The goals are important for facilitating that sense of cohesion, that we are all working towards the same outcome, that we are all working towards the same goal is very important for staff members and for family members alike. Goals also identify who is responsible for what aspect of achieving that goal. And goals are necessary for prediction of outcome. Goals and targets should be realistically achievable. The task should be broken down into small, manageable steps. Effective programs should enhance the well-being of the individual and also raise the morale of family and caregivers. And what we say at the NRH in relation to setting goals is make it a family affair. Family members may not realise that the person with the acquired brain injury has some intellectual disability due to his or her condition or disease. When the person with acquired brain injury forgets parts of conversations, misses appointments, misplaces things, this may be viewed as laziness, indifference, or carelessness. If this happens, family members and friends may need to develop an understanding of what is going on for this person, and setting goals enables that to happen and enhances their inclusion in the rehabilitation process. So we advocate that the family is an expert. The family member, the friend, the carer is an expert in the neurorehabilitation process. The relationship, we have found at the NRH that the relationship between duration and severity of illness and caregiver burden is quite significant. What I mean by this is that the more severe in nature or the more complex the disability, the greater the burden in caregiving to the family member. And in this regard, it is even more important that these individuals are included very early on in the neurorehabilitation process and that they are consulted and involved as active participants in the programme. We've also looked at male versus female caregiving, and one of the issues that has come up in relation to this is that there is quite a difference in coping style when it comes to male versus female caregiving. Many studies have reported that lower levels of reported social support produce a greater sense of burden and distress, and that wives are more likely to report difficulty coping with dependency and having to make more decisions on their own, whereas husbands tend to do better with regard to decision making and strategic management of the individual, but they tend to find more difficulty with less arduous shopping chores, supporting the individual, arranging care from other sources, etc. So husbands tend to keep their wives with an acquired brain injury at home for longer with those practical supports in place. However, However, wives are more likely to report more difficulty with taking on the overall management of the household, etc. Intervention programs, therefore, in this regard, which can be taught to families and to caregivers for use in the home, are very important at relieving that caregiver burden and stress. And many research studies have shown that where intervention programs which are taught to families and caregivers at the post-acute rehabilitation phase show a significant delay then in rehospitalisation and reinstitutionalisation on the individual, for the individual with acquired brain injury. The basic premise of most intervention programs for caregivers is that the course of rehabilitation can be influenced. Most programs, therefore, provide support and education. They teach techniques for communication, for behaviour, for cognitive stimulation, and they promote and advocate activities that help people in their rehabilitation process. Family burden is often found to be significantly reduced following these intervention programs. So what is significant in working with an individual with an acquired brain injury and his or her participation? Well, we know from Professor Ian Robertson at the Trinity College Institute for Neuroscience in Dublin in Ireland that attention is the royal road to learning. And we know that learning and attention is essential for carryover in therapy. Individuals with an acquired brain injury often need, as a prerequisite for inclusion into rehabilitation programs, to have somewhat intact attention and learning. And very often, impaired learning ability is associated with very poor prognosis in neurorehabilitation. So as neurorehabilitation experts, it is our job to maximise and to influence the individual's ability with regard to attention, learning and memory. And this provides a core concept for the neurorehabilitation program, and it should be a core skill that is taught in any neurorehabilitation program. If we can influence the attention and the learning and the memory process, we know that we can also influence the neuroplasticity of the individual. We know from working with patients with acquired disability and acquired brain injury that brain cells that fire together wire together. And it is crucial in any neurorehabilitation program that our individuals are facilitated in every way to influence and to improve upon their cognitive and their physical and their communication abilities. And you'll see here, this is one of my therapists from the program working with a very, very severe acquired brain injury patient at the unit. And we are facilitating his learning and his attention in the auditory channel, in the visual channel, and in the tactile channel. So we use every sensory modality available to us in order to enhance and to influence this individual's attention and learning. The outcome of this, for this particular gentleman, is that as he improves and as he moves along in his neurorehabilitation program, is that he gains insight and awareness into what his difficulties are and into what his needs are, and how we can bring those two together in order to integrate him back into home, into life in the community, and into possibly a workplace. So let's talk a little bit about plasticity, because this is the area of great excitement for people like I who work in the area of neurorehabilitation. We are very excited to learn that an individual's brain cells can be influenced at a neural level by the activities in which they perform. Development of the brain appears to be a lifelong process, as we all know, and new synapses or synapses develop as we age in order to maintain our performance as adults. The principal way in which the brain modifies itself through change at the synapses, which is the area of electrical and chemical communication between the neurons, is very important to us at the neurorehabilitation end of the spectrum. Synaptic plasticity is enduring change at the synaptic level, and this then leads to changes in connections of cortical systems and ultimately to brain reorganization. This is something that encourages us and shapes the way in which we work with individuals with acquired brain injury. There is evidence from the research and from ongoing work in neuroplasticity that there is continuous, spontaneous neuronal remodeling in the mature spinal cord and in the cortex and in the hippocampus. And that synaptic plasticity has been described as a type of conditioned learning, which those of us who work in the area of rehabilitation, modifying behaviour, have known about for a long time. So exposing an animal to a stimulating environment induces synaptic plasticity over hours and days. So why is this important in neurorehabilitation? It is incumbent on us who work in the neurorehabilitation field to provide enriched, stimulating environments for our patients with support in order to explore their intact abilities, in order to improve on their somewhat disrupted abilities, and with the ultimate goal of achieving a reintegration back into community life. Enriched environments, such as those are the associated cognitive demands of focused attention and engaging in diverse cognitive activities, leads to structural dynamic brain changes. And I put a question mark at the end of that because we hope and we anticipate that this is what will happen in the future. So changing synapses, it's encouraging to know that there are these changes happening in animal studies, and we are excited to learn that some of the activities that are being tested in the research laboratories may have an influence and an impact on the way in which we approach our rehabilitation programs. But timing is everything. Acute versus long-term intervention. We know that for patients who sustain a sudden onset traumatic injury, that the earlier we intervene at the neurorehabilitative level, that the better the prognosis. However, with regard to an acquired neurological illness, where somebody is fighting and battling with a disease process, that sometimes the longer-term intervention is what's important. Rapid change in neurons post-injury, as well as plastic changes, are occurring in the weeks, months and years following an acquired brain injury. So the neurorehabilitation program is lifelong, and therefore we must be able to deliver that program long into an individual's life and further into their community and into their vocational life. Knowing when to intervene is also important to avoid dysfunctional synaptic change. For example, plasticity may not be invariably beneficial with regard to phantom limb pain, with regard to seizure activity, etc. So knowing when to intervene, but also knowing when not to overstimulate, when not to overactively control things, is also very important to the neurorehabilitation specialist. Disuse and loss of function, for example, with regard to hemiparesis and activation of motor areas in the damaged hemisphere, or indeed in both hemispheres, is associated with better recovery. So we need to consider the individual's ability and the individual's needs at every step in the neurorehabilitation process in order to custom and tailor-make their program to fit their needs. So at this point, I am going to conclude my presentation today with revisiting the question I asked at the very beginning of my presentation. Who indeed is the most important person in the neurorehabilitation process? Who decides, who plans, who influences and sets the goals and targets necessary for successful outcome in rehabilitation? And what I advocate at the National Rehabilitation Hospital is that the individual with acquired brain injury, with complex physical, cognitive, communication and psychosocial needs, is the most important person. However, he or she can only only participate in his or her program with the support of the whole interdisciplinary team around him. And if we can achieve this in an enriched, stimulating and supported environment, we can successfully reintegrate the individual with acquired brain injury into community life. I'm sorry I can't be with you to address questions and or comments today. However, if you have any questions or comments with regard to my presentation, I can be contacted via email at www.nrh.ie. Thank you for your time.